Hello, everybody. Thank you very much for delaying your happy hour to be here at the last session. So I'm going to be talking about person-centered care within community mental health programs, and I'm excited. This is actually the first time that I've been sharing some very preliminary results of our R01 study on person-centered care planning and service engagement, and I'm lucky to be supported by a very talented group of co-investigators who you can see here, and a team who've helped me through all of this, collected amazing data, and really made this study the success it is. So person-centered care, the sort of larger concept within which person-centered care planning comes, really sort of came to its time probably in the 21st century with the 2001 Institute of Medicine report that made 6 recommendations to bridge that quality chasm, and one of them was that we need to deliver person-centered care. Also within behavioral health, I think the Freedom Commission report in 2003 really put person-centered care on the map. So in medical settings, we often see it as patient-centeredness, and really there've been a lot, again, in the sort of last 2 decades, and a lot of efforts to understand what it is, to conceptualize it, to operationalize it, and to measure it. Person-centered care planning actually emerged in the 1980s in services for people with developmental disabilities. That was the first time that we saw, and those were those efforts to really improve self-determination within those settings, mainly residential settings. And so in mental health, I think the mental health recovery movement and the shift of the mental health system to provide recovery-oriented services is where we saw person-centered care really then emerge, being one of the principal components of recovery as defined by SAMHSA. And then I think integrated health. So we've been talking quite a lot about collaborative care at this conference. So person-centered care, again, is often cited as a sort of organizing principle for understanding how we coordinate care, that it revolves always around the person and responds to their individual needs and preferences. So that's a sort of overall principle. So how does it filter down into different community mental health programs? So it varies in terms of how much it's actually articulated as a program goal within these different community mental health programs that have different structures, different intensity. But as you can see here, it's actually in a set of community treatment team. It's actually articulated in the fidelity measures. There are 4 items. In community support programs, which are rehabilitative services, again, in the fidelity measures. Youth adult services talk about having a client-centered approach. And then in group homes, residential settings, that a service plan should be individualized. So while it's widely agreed upon, person-centered care is a very good idea. When you actually get down to it and talk to providers about what does that mean in terms of the particulars of their day-to-day practice, then it becomes more difficult for people to really make this concrete. So Janice Tandora and from Yale Program for Recovery and Community Health, and Diane Grieder, developed a very specific and manualized recovery-oriented practice, which they call person-centered care planning. So care planning, service planning, treatment planning, but it is that process that really shapes care. It's the blueprint for care, which all programs undergo a service planning process. So they really specified this practice. And probably in that specification, which they did, which was important, was they articulated what it was and what it was not, yes? It's a tendency for everybody to say they do person-centered care. People don't want to think that they don't. But actually there are distinctions in this practice. And if you kind of look at this more traditional approaches, so that tends to be more pathology-driven approaches, and are more paternalistic, and then for the person-centered, much more focus on self-determination, choice, strength-based, transparency, and community integration, using natural supports and really trying to think beyond this mental health system. So they embedded these principles into person-centered care planning, into the service plan. So this really is not just a technical practice, it's a value-based practice. It requires really a reorientation in terms of how providers think about their work and how they collaborate with service users. So these you can see are the principles that are embedded within person-centered care planning, and then how does that actually translate in how you put together a service plan. So really everything should roll out from that goal. Yes, that goal should be individualized, it should be meaningful, and then you back up towards the objectives. What do you need to do to get that person there? Objectives are not goals, they're not endpoints. Taking my meds is not an endpoint. It's a way to get you where you want to go. And then importantly, you still have to be able to bill for those services. So there is not an incompatibility between doing really person-centered care planning and getting reimbursed for your services, which is a reality that all agencies have to pay a lot of attention to. So it also has to meet billing criteria. So once you've sort of operationalized it, you've defined a practice, then how do you measure it? So in this study, in the R01, we measured person-centered care planning by two ways, the subjective, objective. So subjective, it was self-report. We used the person-centered care questionnaire, which is a self-report. To what extent do you think that you're doing person-centered care planning? 36 questions going into quite a lot of detail about all these different aspects. And when we looked at the data, the baseline data, we interestingly found that the higher that people rated themselves on recovery knowledge, which is that foundational knowledge for this practice, the higher that they rated, well, actually, no, I'll reverse that. The higher that they, the lower that they, this is actually not, it's not an intuitive finding, which is why it's quite easy to get it wrong. So the lower they rated themselves on recovery knowledge, then the higher they rated themselves on person-centered care planning, whereas somebody who had quite good recovery knowledge would say, no, I'm not that good at person-centered care planning. So I think what we took away from that was actually the difficulty of people assessing their practice at a baseline level. And when we sort of dug a little further, we found out actually that there's this whole body of research in psychology called the Kruger-Dunning effect, which is that people don't know what they don't know. So that told us that we had problems with subjective assessment at baseline with this socially desirable practice, but difficult, complicated practice that people were not good at rating themselves. So that sort of told us that our objective measure would be important in this study. So this particular study is looking at competency in person-centered care planning, and we're looking across service programs within community mental health clinics, but using an objective fidelity measure rather than the self-report measure. And so that's embedded in this larger randomized controlled trial that we're doing of person-centered care planning. So we just looked at the service plans from baseline, and we just took them from 8 community mental health clinics in a northeastern state. So this is the development of our objective fidelity measure, which we called the PCCP assessment measure. And this had already been developed and refined by Janice Tondora and Diane Greta while they were they've trained extensively in this practice. They've trained at the state level. They've trained at the local level. So over years, decades, they've been developing this fidelity measure to capture those sort of core service plan domains. And so then in the study, we further refined it. We pilot tested it with 2 raters and 8 service plans across 2 of our mental health clinics. And we refined it to a 13-item measure and anchored it in terms of a 1 to 4 score, which indicated different levels of competency. And you can see approaching standard, meets the standard, and then 4 exceeding the standard. So we also then worked more to identify within that different subscales, which indicate different proficiencies in the aspects of person-centered care planning. So this is the measure developed by Janice Tondora and Diane Greda. So in terms of the 3 different scales, one is sort of the heart of it, which is how recovery-oriented is this plan in these core service domains. So looking at the assessment, looking at the interpretive summary, and then your objectives and your goal statements. And then overall, are you referring people to broader activities in the community? Are you strengths-based? Are you using natural supports? Then the process, just 2 questions in terms of the process. So person first language, and also that it's a collaborative process, that there's an indication of that. And then technical proficiency, so 3 items like is this a service plan that would meet billing requirements? It's a technically proficient service plan. So we did chart review. We randomly sampled service plans completed by the direct care providers from the baseline. So we did 20 service plans from each of the 8 agencies. We have missing data on 5 plans, which is why we had 155 in total. And these were the program types. So this was just one state, so it represents the sort of array of community mental health programs in that state. We categorized one grouping into other, which included quite a few programs, but in peer support and dual diagnosis. And then we scored, and we actually chose for ease of interpretation, we collapsed it to 1 being competent and 0 being not competent. So total score range from 1 to 13. And then this is actually the reliability from all the service plans that we reviewed for the whole study, which we had a total N of 798. Charts were reviewed, their service plans. So reasonable reliability in terms of the Cronbach alpha and in terms of the inter-rater reliability. So each site, we had independent raters, but they co-coded a small selection of service plans to check on their reliability. So this is what we found. I hope people can see this in the back, because I know I've been in the back and not been able to see so much, but I'll try and talk you through it. So this was just the distribution by each item, and what you can see is that people are doing well in terms of the process part of it, the recovery-oriented process, with actually the large majority managing to be competent on those. Some of the recovery-oriented service plan and some of the technical proficiency questions, but where they're struggling more is on some of these issues of, are you thinking and planning on things beyond services in your objectives? Are you integrating strengths? Do your objectives have individualized dates? So that's one thing that often happens, is they just put these sort of, set dates that sort of are meaningful to their agencies but not meaningful to the service user. And natural supports and connections, which is a key part of this intervention. Few people are managing to incorporate this into the service plan. So this is the overall distribution. So you can see that the majority of service plans are sort of coming around 6, grouping around that mean point of 6, which means, half the items they're competent on, half they're not. So then we looked at it across program, and so you can see that assertive community treatment in the overall scores comes out as being the most competent in terms of person-centered care planning, with youth adult services second, and then community support programs. And then really at the lowest level, outpatient therapy and partial hospitalization to therapeutic programs. The technical proficiency, it seemed like actually most people were doing that and doing that well. Interestingly enough, slightly different programs that did well on that, outpatient therapy and residential, but still assertive community treatment doing the best. And then if you look at the recovery-oriented process, really the story is, yes, most people get that well, they're doing that well. But again, we have assertive community treatment and young adult services doing well. So this is where people fall down the most, which again is that heart of it, which is on the recovery orientation of the plan, really putting in those really key aspects. Again, we have assertive community treatment doing, being the most competent, and outpatient therapy having the lowest levels of competency. So what does this all mean? Very preliminary data, so we have to be very cautious in thinking what this means, but we did seem to find that while people were doing all right at the process, all right at the technical aspects, they were struggling with the real heart of this intervention, the recovery orientation. We did find significant variation across programs with assertive community treatment and community support programs showing a highest level of competencies. So as I said, very preliminary descriptive findings. We have much nesting. We have plans nested in clinics, and we have clinics nested in states. So we have to delve deeper into that and be able to adjust for that. And also our other program was probably too broad to be meaningful. So what are the implications? So it really seems that we still have some way to go. Hopefully, as we've intervened and trained some of these clinics, we will see that in our next waves of data, that we will move the dial on some of this. But just looking at clinics as they are before training, we see that there's quite a way to go in terms of actually being person-centered, despite what they are saying and what they are self-reporting. And the bit that seemed to be most challenging is think about natural supports, think about a life beyond mental health services. Yes, this is what seems to be challenging for providers in terms of how they shape people's recovery journey. But the programs that specified person-centered care planning in their fidelity or in their goals seem to do better. So fidelity seems to make a difference if you specify it. And I think overall this shows that we need more objective measures of person-centered care, which is this sort of central component now to medical settings, but more and more so behavioral health settings. But we need to, one, really operationalize it and then be able to measure it with integrity. So thank you.
Next we'll hear from Peng Hung.
Thank you, Mike. And thank you, Victoria, to introduce the importance role of community mental health programs in microscope lens. So this presentation is gonna be a larger scope and talking about the association between state community mental health centers availability and suicide mortality. Before getting into the presentation, I would like to say a word thanks to my co-authors and mentors at Yale School of Public Health. Thanks. So we know suicide is a global issue, but among most OECD countries, we saw a decreasing, a falling suicide mortality rates among them, while the United States has been going into some kind of different directions. The recent recent CDC reports also documented almost all states but one state have experienced rising suicide mortality rates from 1999 to 2016. And for decades, suicide has been the leading cause of death in the United States. It claims over 40,000 lives every year and nearly 45,000 in 2016. Sadly, only about half of individuals with serious thoughts of suicides received mental health treatments in the past year of a 2017 survey. So the dramatic increasing in suicide has led some to speculate that the reductions in hospital-based psychiatric beds may have contributed to this increase in suicide mortality. The most recent study have found no associations between the decreased state hospital psychiatric beds and increased suicide mortality. But very few studies and reports have thinking about in the era of shortages of hospital-based psychiatric services, there were another increasing role of community mental health programs. Recent anecdotal reports also brought attention of the effects of community mental health services closures or declining availability on access to care for individuals diagnosed with serious mental illness. And we know community mental health services may be the only specialized mental treatments in the community for a lot of low-income populations. Among all the mental health facilities, community mental health services have the largest proportion accepting Medicaid and uninsured patients. Almost all community mental health centers in the United States accepted Medicaid patients, and over 90% of them accepted uninsured patients. So this study really wanted to document the changes in number of community mental health centers in the United States in the recent year, and further looking at how these changes will be associated with suicide mortality. We derived the data mainly for the suicide mortality from CDC Wonder data, and in the state level, we also got the number of hospital-based psychiatric units and community mental health centers from National Mental Health Services Survey. In order to incorporate the changes in social demographic characteristics in state level and the social economic characteristics, we got the data from Area Health Resources File and US Census data. The key outcome here in this study is the state level deaths from suicides in 2014, 15, and 16. We use the same definition as the CDC report using ICD-10 diagnosis codes to calculate state level number of deaths died from suicides in each year. And the key independent variable in the study is the state-level annual number of community mental health centers, which is defined by, it's actually the self-reported, but mostly is licensed or certified by the state government that where the community mental health centers located. So if they are specialized in providing mental health services, including 5 core specialized mental health services, according to the definition in the National Mental Health Services Survey, then they will be counted as the community mental health centers, which is separately identified from general outpatient mental health centers or other partial hospitalization programs. So with these 2 key data sets, we use state identifiers to link them and include all 50 states and DC for 3 years of analysis. That leads to our unit of analysis at state year level. to look at the associations between the community mental health center availability and the suicide mortality in the state level, we use generalized linear time series analysis in every state, have 3 observations. We sequentially adding these following covariates into the models to look at within states association between the community mental health services availability and the suicide mortality. The models accounted for state population size and the state heteroscedasticity. So we kind of count those larger states more important in these models. We also accounted for time sequenced nature of the suicide mortality within the states and by clustering the standard errors in the state level. Here are the results. So we found that the number of community mental health centers decreased from 3147 in 2014 to 2624 in 2016. It's about 523 fewer community mental health centers across all states. And not surprisingly, there were increasing trend for suicide mortality per 100,000 persons in the states from 15.37 to 16 between 2014 and 16. Then we calculated the percentage change in the suicide mortality rates and in changes in community mental health centers per 100,000 persons. Across those states, we found about 4% increase for suicide mortality rates within just 2 time periods. And the decreasing number of community mental health centers were by 17%. So that leads to one question. Whether states with higher community mental health centers supply would have higher or lower suicide mortality? To answer this, we calculate the average number of community mental health centers across 3 years per 100,000 persons, as well as the average suicide mortality across 3 years for each state, and plot them into the scatter plot. We found that states with higher suicide mortality rates actually have higher community mental health centers. It's not really surprising. But this figure obscures the information within, of the changes within each state. So we want to look at not only the between state differences, but also within state differences. First, we account for the number of psychiatric hospitals per 100,000 in each state, and looking at the association between the community mental health centers availability and the between state differences in terms of suicide mortality. And this is consistent to what we saw in the between state association. It's positive associated, but it's not significant. When we accounted for time invariant differences between states and the time trend common across all states, we found the sign split. That means within each state, on average, one community mental health center change may be associated with lower suicide mortality rates, but not significant. 80 state-level social demographic characteristics and socioeconomic characteristics gains more efficiency because we account for their differences and changes in terms of socioeconomic and social demographic characteristics. In the final model, accounting for state, time-fixed effects, age, race, and low-income characteristics, a distribution within state, we found one more community mental health center per 100,000 persons in a state would be associated with 0.67 lower suicide mortality. Again, the average is about 15.4. 15.4 per 100,000 as a suicide mortality across all states. But to illustrate what this means, within each state, we calculated the adjusted suicide mortality for each state for each year. And then link the 3 data points for each state, the same states linked together to see what's the trend out there. Again, this is adjusted for time differences, time trends across all, and the time invariant differences between states, as well as their social demographic characteristics and the percent individuals below 200% federal poverty level. And we saw what? We saw within each state, positive changes in community mental health centers availability will be associated with negative changes in suicide mortality, or you can say the other way around. But this study really actually using a very large scope and macro scope looking at state level data, because we relied on National Mental Health Services survey data to look at this issue, while really no one has been looking at this, the role of community mental health centers in the suicide prevention. The data actually only includes responding facilities, and the item response rate increased from 90% to 96% between 2014 and 2016. So we may expect there were fewer, we may underestimate the community mental health centers in the earlier year, but we still see the decrease over these 2 time periods. We focus on community mental health centers because we found the important supportive services for suicide prevention. But there were other outpatient specialized mental health services out there in addition to community mental health centers. And because the data only started identifying community mental health centers not until 2014, we only have 3-year data to look at this issue, but we still saw a significant association between the changes in community mental health centers availability and suicide mortality. And again, it's state level identifiers. More granular data may allow us to look at these state-specific trend, and then looking at a microscope thanks to in this issue. So that leads to a potential omitted variable bias, such as state mental health funding or the state economic changes within these 3 years. They may be associated with both community mental health centers availability in a state and the suicide mortality. So overall, we still provide very important information on this changing landscape of number of community mental health centers in the United States. It's just in 2 time periods, the decrease was by 17%, and we found this decrease were associated with the within state suicide mortality after controlling for time invariant state differences, time trend across all, and the social economic, social demographic characteristics. After back channel calculation, we found this 0.67 can lead to 370 more suicide deaths in the United States due to the a reduction in number of community mental health centers in between 2014 and 2016 alone. So this leads to one very important implication. Surely the results we found really wanted to point out there were a decreasing trend, and this suggests urgent need to develop practical and accessible treatment models for individuals with serious mental illness, particularly for those living in the areas that were experiencing the decreasing of community mental health programs. This ends my presentation, and I welcome any questions you may have later. Thank you.
Next, we'll hear from Paul Barr.
Hi, folks. Sorry to keep you so late. Let me see. I'm so used to working on a Mac. Here we go. I'm going to try my best to beat the clock. I think that's the incentive here for the little light system. Am I meant to press this to start it, or does it start automatically?
They start in the back.
Oh, okay. Hi, so my name is Paul Barr. I'm a health service researcher from Dartmouth College. And I'm going to talk to you today about, please slow me down if I speak too fast, by the way. I'm Irish, and I get into a story, I start really going. But I'm here to talk to you today about the evolution of a decision support tool we've been developing at Dartmouth for depression for the last few years, and how it's really evolved from quite a simple paper tool to something that's now still quite simple but delivered online. And some preliminary work, so we really are just starting out with this. We have a large team of folks involved. This is just the little team involved in this current pilot project. But we have patient partners, consumer, community partners, and other experts from across the field who've been working with us over the last few years. This project, the current project, wasn't funded, but I just disclosed some of my current funding. And this is just a bit of an overview of what we're going to go through. So I won't spend too much time talking about depression in America, because I think most folks here know about that. But I will talk about the lack of shared decision making, and how we have went to develop a tool, and how that's now been piloted online and linked to screening for depression online. So essentially trying to provide real-time decision support along with depression screening. Okay, so 1 in 5 folks will be diagnosed with a mental health condition in any given year. We've heard this multiple times today. And over the course of our lifetime, 50% of people will experience a mental health condition. And depression is the most common. It's the leading cause of absenteeism in the workplace, depression. Accounts for around 68 million lost workdays. And that translates to about $23 billion lost to the economy. Now, we've been improving in terms of treatment options, and we've seen this in some of the prior talks. We have new pharmacotherapies. We have new psychotherapies, both online and in person, which have been demonstrated to be effective. Despite this, only 30% of folks who need treatment actually receive it. And there's a number of barriers to receiving treatment. One is that the perceived ability to actually pay for treatment. Secondly is folks don't know where to go. They're not too sure where to receive the treatment that they want. And even those who know where to go, they don't have the childcare, they don't have the transport, they don't have the time from work to actually go and get that treatment. Many folks feel stigma around their condition. This poster I found, it's from 1936 in New York City, and it was for folks who were diagnosed who had syphilis. Almost 100 years later, and we're still dealing with stigma in healthcare. Like, how can we not address some of these really important, pressing issues from the year gone by? And folks don't believe, well, it's not that they don't believe, they don't really know the evidence around the treatment options, so it makes them less likely to engage in treatment. So we overcome all these barriers, and yet, even those who actually make it to treatment, only 16.5% receive adequate treatment. Like, that's unbelievable. They've actually overcome so much to get to see us, and then they don't get what they need. Some people get too much, some people get too little, but not a lot get the right amount of treatment. Another huge issue, and it really touches on the point that Greg Simon brought up earlier, is we're not doing enough to find out what matters most to the person. And so we end up, people are getting treatments that aren't aligned with their preferences. And this situation then ensues. Despite a preference for psychotherapy, many folks end up on antidepressants that they don't really want, and then they don't engage in the treatment. In our own research, we conducted a national survey, and we found that only 18% of consumers surveyed, those 1,000 people from across the country, reported being engaged in a treatment decision that they felt was high in shared decision making. We've done other work in primary care for other conditions, and the average is around 60 to 65%. These folks are being really disenfranchised. And primary care appears to be the poorest performer. And in general, folks are dissatisfied about, their engagement in the decision-making process. When we bring the treatment options and align those with the consumer's preferences, we know that it actually improves behavioral and health outcomes. One way of doing this is through decision support. There's been 118 trials, maybe more by this point, of decision support tools. And one of the key findings is that they can improve the alignment of treatment chosen with the person's preferences. However, in depression care, there aren't very many decision aids. And probably the most well-known one was by a colleague of mine, Annie LeBlanc, from the Mayo Group, who's now at University Laval. And she designed a beautiful decision aid for depression, but it focused only on antidepressants. It didn't talk about the other approaches like watchful waiting or psychotherapy. Those sort of first-line approaches, folks need to make the decision, what line do they want to go down? And so our team wanted to go and try to develop an encounter-based decision aid. And what that is essentially, it's not overly comprehensive. It's meant to be simple, short, and gist-based, so that it provides the scaffolding to a conversation between a clinician and a patient. So I have a bunch of these things printed off that I can give out, but this, I think, is version 27. There's probably going to be more versions after that, and it's based on multiple projects over the last 3 years. So I'm not going to talk much about the development because it's not the focus of the presentation today, but I will just quickly go over it. So we developed the questions for our tool through a national survey where we ask consumers and clinicians what their information priorities are when making treatment decisions. We then conducted cognitive interviews with a pilot of our tool and several stages of cognitive interviews with consumers and with folks who have no history of depression and clinicians to try to create a tool that was understandable and easy to follow. And then we piloted this tool in primary care with 4 clinicians. And what we found was that folks liked the tool, it was easy to use. The problem was it wasn't being used correctly. So individuals, patients were not getting to see the information before they visited the doctor. And so that led to our third project, was to say, well, why don't we design a system that can provide the PHQ-9 screening in primary care on a tablet and link that to decision support immediately so they get the results, and then you get to see the treatment options that you could discuss with your clinician. And so we had that project, and it's gone pretty well so far as well. One of the things that come from this, and it was from a community partner from Mental Health America, Teresa Yen, was that we could actually take this and bring it to a much bigger scale. And I'm sure most of you are familiar with the Screening to Support initiative launched by Mental Health America 2014, where they offered online screening for multiple mental health conditions, and around 3,000 screens are completed a day. That includes the PHQ-9. And so the idea was, well, for these folks, and we know that they haven't, many of them actually have any history of depression or any sort of form of treatment or seeking treatment, but they have these diagnosable conditions, possibly. If we could actually connect them with some information about what the treatment options are, maybe we can overcome on that barrier of lack of knowledge and lack of access to information. And so that was essentially the gist of our project, was to determine the feasibility and acceptability of implementing online decision support linked to the PHQ-9 screen with Mental Health America. So this is how the sort of screening page looks. I'm sorry it's small. I think we'll all apologize for a small screen, but essentially over a 30-day period, in the last October to November, anyone filling out the PHQ-9 screen then had the opportunity, they would see the result as normal, but they had an opportunity to click on a further link to find out more information. And if they clicked on that link, they would then see our decision support tool. Now, a limitation of this project was that it wasn't funded, so we just got the link onto the webpage. The placement of the link wasn't ideal. It was at the very bottom, so someone had to actually scroll down to find it, which I think really impacted quite badly the sort of transfer of folks from results to decision support. We collected information. It's typically Mental Health America collecting information on demographics, mental health history. We then asked further questions of those who actually viewed the decision aid. So, was it helpful? Have you been receiving current treatment? Are you willing to discuss symptoms with a clinician online? I'll come to that sort of toward the end. So this, I had an updated version of my presentation, but this is fine, it'll work. So these are the characteristics of the 75,000 roughly individuals who completed the PHQ-9 screening on Mental Health America over a 1-month period. We can see principally female, many younger folks there, so under 17, 18 to 24. And the LGBTQ community and student community were represented quite well in the 75,000. In terms of PHQ-9, the scores range between moderate to severe. Now, we ran a multiple regression model to look at the characteristics of those who then went on to look at the decision aid, and there was 599 from that 75,000, so about 8%. And what we found was that folks of increasing age, females, people with more severe depression, people with suicidal ideation, students and members of the LGBTQ community were more likely to actually go and find that information. So they actually scrolled down, found it, and clicked onto it to go and look at this. Whereas we found that members of the Black and African American community and people with more than one race were less likely to go and look at this information. Although there's a caveat, there were really quite small numbers of members in those communities. So we asked folks who viewed the decision aid, are you currently receiving treatment? Only 13% were, 86% were not. So this is a population of people who really have no history of treatment, where this tool could be really helpful. And 46% of them thought it could be helpful. 45% weren't too sure, which isn't surprising. This is probably new and scary. And only 6.3% didn't think it would be helpful for them. What's interesting is that 72% of the folks who looked at the decision aid said they would talk to a clinician online about their condition. And we want to look further into that. So we ran a regression model to find out the characteristics of those who would look online or talk to a clinician online about their condition. And there wasn't really much happening. We did see some large odds ratios for members of the Black and African American community and for those with more than one race. However, the numbers are really, really small in those groups, so I can't really read too much into that. And there was a sort of trend of being less likely to look at this information as people got older, but again, we didn't have enough data to actually find something of statistical significance. So this work's kind of preliminary, but it's demonstrating that the provision of a real-time decision support to PHQ-9 screening online is feasible and possible. Even with poor placement, we still reach those we think are at highest need for this information, those with highest levels of depression and suicidal ideation. And a high proportion of folks would be willing to consult with a clinician online. Limitations of that was an opportunistic sample over this 1 month period. We had low numbers by some of the groups, so we couldn't really do further analysis. And sort of the people answering the question for would you speak to a clinician online were folks who actually want to look at a decision aid, not the other sort of larger population, which we would love to get that question in there with Mental Health America to find out what their views would be. And I mentioned the poor decision aid placement. So the implications are that we think that there's a signal here, that there's actually an opportunity to develop a new model of depression care and service delivery. And we're working with Mental Health America to develop a completely online model of care for individuals with depression from screening right through to treatment. So that's kind of our bigger goal for the upcoming sort of year, is to try to really flesh that out and start in studying that potential model. I beat the clock. Thank you.
Next, we'll hear from Dr. Brittany Rudd.
There's a bit of a height difference between us. Okay, so I am a postdoctoral fellow at the University of Pennsylvania, and I'm going to be talking about Pennsylvania's efforts to build a citywide trauma behavioral health care system, and I'm going to be focusing on the naturalistic client outcomes. Starting in 2012, and funded by a SAMHSA grant, the City of Philadelphia developed an academic community partnership called the Philadelphia Alliance for Child Trauma Services. That was an initiative to roll out trauma-informed care across all of its community behavioral health agencies. There were 4 goals for this initiative. to develop an integrated system of child trauma providers, build capacity for trauma screening and assessment, build partnerships between PACS providers and other child-serving systems, and increase the delivery of evidence-based practices for trauma. And the cornerstone of that was the implementation of TFCBT. The implementation outcomes for this initiative have been already published. You can read Betas et al. 2016. I'm going to be focusing in on this idea that once implementation has happened and we have interventions out in the community, are they still effective for the youth that receive those services? So I'm going to be focusing in on the effectiveness of the TFCBT provided as a result of this initiative. For those of you unfamiliar with TFCBT, it's the gold standard for treatment for child trauma, and it's important given that the vast majority of youth will experience a traumatic event by the age of 17. It's a short-term evidence-based intervention that has 8 practice components, and as we heard earlier from Hannah Frank, the trauma narrative is key. So my goal was to evaluate the effectiveness of trauma-focused CBT, or TFCBT, which is an empirically supported treatment on youth outcomes. And I did that in 2 ways, by first evaluating the change in symptoms of youth that received TFCBT, and then benchmarking their improvements up against the original efficacy as well as effectiveness studies. So the youth in this sample are 114 youth who were identified by their PACS therapists in the community as needing TFCBT. They were then approached by the evaluation team at Penn to see if they'd be interested in being in our evaluation. The youth that consented and assented to the evaluation were assessed at the initiation of treatment and then every 6 months until they terminated treatment. We used, for our follow-up analyses, we used the last available follow-up date, which was primarily termination, but if we didn't have termination and we had their 6-month follow-up, we used that. To evaluate changes in symptoms, we looked at the Child PTSD Symptom Scale, the CPSS, both the symptom severity and functional impairment, as well as more general psychopathology using the Ohio Youth scales, including problem severity and their overall functional impairment. To measure change in symptoms over time, we used linear regression with FIML estimation to account for the missingness that occurred in nutrition. We had about 70% of youth who were at baseline represented at follow-up, and there were no differences in demographic data on missing. We then calculated their effect sizes from the effect sizes of these from pre to post or pre to follow-up, and then calculated reliable change indices to see the percentage of youth who had reliable improvements. So jumping into results, for the CPSS, the clinical cutoff for severity is 16. We did find small but statistically significant improvements in youth symptoms from pre to follow-up. Again, these were small effect sizes, and we found that about 33% of youth had reliable changes or reliable improvements in their symptoms. In functional impairment, there is no cutoff for clinical significance. There was again, small but statistically significant improvement in their functional impairment. Again, small effect size, and 29% of youth had reliable improvements in their symptomology. And then switching over to more general psychopathology, we're looking at the Ohio Problem Scale. The clinical cutoff is 25. We found, again, small, statistically significant improvements, and about 48% of youth had reliable improvements from baseline to follow-up. And what's really encouraging here, whereas going back to the previous slide, which I don't know how to go backwards, but if we're looking at the CPSS score, even though they improved over time, they still were experiencing clinically significant levels of trauma. Here, with general psychopathology, we do see that they do go below the clinical cutoff by follow-up, so we're actually seeing pretty significant changes here. In overall functioning, the clinical cutoff is 60, and we did not find improvements in overall functioning. It was not statistically significant, not clinically significant, and only 17% experienced any reliable improvement in their overall functioning. So then we know now that for many indicators, there were small statistically significant improvements in how these youth were doing from baseline to follow-up. But then we don't have a comparison group, so what do we do for effectiveness studies? And one methodology is to benchmark effect sizes against the seminal studies. And it's been done with other interventions that are available in the community. So we compared our improvements to the original multi-site efficacy study of TFCBT, as well as an effectiveness study that was done in Norway. So let's compare our samples. So in the PACS evaluation, we had 114 youth with a range of ages between 5 and 19 in the United States context. In the efficacy study, there were 229 youth between the ages of 8 and 14. They were in the United States. In our study, we had heterogeneous traumas. In the Cohen study, it was sexual trauma. And then in the Jensen study, 156 youth between the ages of 10 and 18 in Norway, and also heterogeneous traumas. So looking at differences in demographics, you can see for PACS, we had a fairly equal distribution of males and females. The Cohen and Jensen study had statistically significant more females in their studies. If we look at race and ethnicity, we had a very diverse group. It's 45% African American, which is significantly more African American youth represented in our study in comparison to Cohen and Jensen. We also had more biracial youth, and I also believe Hispanic youth. So how do we compare in terms of our effect sizes? So we had small across the board, as I had mentioned earlier, and in the Cohen study, they had medium effect sizes, whereas in the Jensen study, there were large effect sizes. So why might this be the case? Why is it the case that, as we saw, and as I mentioned earlier, we had successful implementation outcomes, and now that we're providing these services in the community, while kids are getting better, they're not getting better to the same magnitude as they did in these original studies. We talk very openly, because this is an academic and community partnership, so we talk very openly with our clinicians about what do they see as barriers or challenges. And one of the things we talk a lot about is the disadvantaged youth that they're seeing. So simultaneously with this talk, there's another talk about PACS happening about the sociodemographic characteristics from census data of these youth. And these are youth living in high crime communities with a lot of poverty. So perhaps our youth, because of their sociodemographic difficulties, it's just more challenging for them, and TFCBT is not working as well for them. Then we think about the organizational barriers. TFCBT was originally designed to be 90 minutes, and here we have 60-minute sessions. TFCBT is also supposed to have a lot of family engagement. There are family sessions, and it was very challenging for clinicians to have families as involved as they'd like in the process. There's also the difficulties of these kids being in really high crime areas and experiencing chronic trauma, polytrauma. So TFCBT has the idea in mind that you are now safe. These kids are not safe. And so perhaps that is the challenge that we're experiencing. There was also this idea from many of the clinicians that maybe they need something other than TFCBT first. Often the youth ended up in these clinics because the parents were concerned about the externalizing symptoms. So they came in because of the anger and the aggression, and they wanted those things treated first. And that when the therapist said, we are gonna treat the trauma, that they felt as though the parents weren't hearing that, and instead they wanted something else. And then if we think about the population, again, these are younger youth. They're more diverse, and they're experiencing chronic trauma. So perhaps TFCBT needs some adaptations in order for it to be effective for this group. Wow, wow, I really did a great job with my time. So we can talk about implications all day long. But I think what's really exciting here is that despite the very many social stressors that these youth are facing, they are getting better. And therapists are seeing that these youth are getting better. And by benchmarking our results, which is novel for TFCBT, and really is only, this kind of method has only been done in maybe 2 other treatment outcome studies, it provides us opportunities to think through how are these interventions working in the communities for which we develop them. And when we implement them, we want to make sure that these interventions are still providing the same magnitude of effect for youth. And so by having these results, we can continue to talk to therapists and treatment developers about how we can make these interventions more effective now that they are functioning and being used in the community. And that this type of work will continue to inform the work that we do with youth. That's it.
So Joseph DeFerrio is our final presenter.
Can I just close out of this? My name is Joseph DeFerrio. I work in health informatics at Weill Cornell Medicine in New York City, and I'm here on behalf of my colleagues to present our paper on using electronic health records to characterize prescription patterns, specifically focusing on antidepressants issued by non-psychiatric clinicians in outpatient settings. So as many of you probably know, treatment for depression is increasingly occurring in the primary care setting, not by psychiatrists, but in primary care, and nearly 12% of the U.S. population is taking antidepressants according to estimates. And further estimates suggest that upwards of 30% of those antidepressant prescriptions are issued for off-label indications. And those estimates are based on one study using EHR data and an e-prescribed system in Canada, and the other one is on Georgia Medicaid patients. So a lot is still unknown. Believe it or not, a lot is still unknown about antidepressant prescription patterns in outpatient settings. But electronic health records provide a platform to study these prescription patterns because they have longitudinal data collection, they cover multiple care settings, and they have both structured and unstructured data. So structured meaning like ICD-9, ICD-10 diagnosis codes, and unstructured data would be like clinical text or like clinical care notes. So why do we do this? To characterize non-prescription patterns of antidepressant according to drug labels and evidence assessments. And we characterize them as on-label, evidence-based, and off-label using structured outpatient EHR data. And we chose structured because it's easily collected, it's easily analyzed, and almost every institution can do it. To analyze clinical notes would require natural language processing, and not everybody's equipped to do that, and it can be really challenging. So we employed a retrospective study design looking at outpatient EHR data. So we mined our EPIC EHR for demographics data, encounter details, diagnosis, like I said, ICD-9, ICD-10, and medications or prescriptions, I should say. The antidepressants were identified using NDC codes provided by the NCQA. This might be hard to read, so I've got some notes for you. So our eligibility was essentially patients aged 18 or older had received had received at least one antidepressant prescription in the outpatient setting, and they'd had a history of structured diagnosis history. So we originally had written our IRB to include all patients that were age 12 and above. So that was 400,000 prescriptions and 123,000 patients. And we collected our data in mid-2016. But due to EHR implementation and when we collected it, we wanted to restrict it to full years, so we actually just limited it to 2010 to 2015. And we also assumed that one, psychiatrists who are prescribing antidepressants are aware of the on-label indications for antidepressant drugs. They know how to prescribe them. They're familiar with the the territory. But we also removed them because psychiatry didn't come online in the EHR until later in the system. So they actually had very few antidepressant prescriptions, and for a long time they're actually blinded for most investigators because of the sensitive nature. And then we also removed any prescriptions with no diagnosis data. Believe it or not, some people were receiving prescriptions but had no diagnosis data, at least structured diagnosis data. So that left us with 35,000 patients and 140,000 prescriptions. So we looked at antidepressant prescriptions, but I don't know if any of you are clinicians, but as you know, diagnoses aren't always made during the clinical encounter. So we used a series of look-back windows where we matched each prescription to its all the patient's corresponding diagnosis over a period of up to 5 years before. So in this window, we have a prescription being matched to all prescriptions that patient received in the previous year, 2 years, 3 years, 4 years, and 5 years prior to their diagnosis. And we did this because a lot of times patients who receive antidepressant prescriptions are suffering from chronic conditions, and 5 years is not unreasonable for someone to be suffering from a chronic condition. So when we looked at the drugs, when we examined antidepressant prescriptions specifically, we used this compendium, the Micromedics Drug Dex system, which is an authoritative compendium that the CMS uses to determine reimbursement for drugs. And this contains, I can't show you too many screenshots because it's a subscription base, so I didn't want to infringe on that. But essentially, they have a list of FDA uses and non-FDA uses. So in our case, we labeled FDA uses as on-label, non-FDA uses as evidence-based, and all others as off-label. And evidence-based indications were only accepted if they met a minimum threshold that we use based on class of recommendation and strength of evidence. So for just a reference, class of indication, so class of recommendation 2A would mean moderate benefit is greater than risk. Evidence categories, category A would mean high quality evidence from greater than 1 RCT, and category B would be moderate evidence from greater than or equal to 1 RCT. So we use a pretty strict criteria to determine evidence base. This is the way the prescriptions were classified using the different look-back windows. I understand it's probably hard to see in the back, but on the left of the graph, we have day 0, on which the prescription was issued. The blue is on-label prescriptions, gray is off-label, and orange is evidence-based. So at day 0, the total prescriptions don't add up to 100% because not everybody received a diagnosis. So in fact, the on-label, that being said, the on-label prescriptions was actually 27% and off-label was 31%. But as we go back, the number of on-label, as we increase the look-back window, the number of on-label prescriptions increases, the number of off-label prescriptions decreases because you start to incorporate diagnoses that were made in the past that can be considered on-label for that medication. On day 1, like I said, only 70% of the prescriptions had a structured diagnosis. And at 90 days, the 1 year look back, 98.6% of the prescriptions had a structured diagnosis. So even going back 1 year, not all prescriptions had a diagnosis, had a history of diagnosis. So we wanted to validate this. You can match prescriptions to diagnosis all you want, but you want to see how accurate it is, right? So we randomly selected 1% of the unique patient charts for those that received a prescription of off-label use. We compared the diagnosis in the EHR to those that were listed in our data set, and then reviewed clinical notes to determine the physician documented indication, and then we also did that for the on-label prescriptions. So this is a list of prescriptions. The first line is the number of prescriptions and some of the diagnoses that can be listed on these prescriptions that were associated with the prescriptions. And then the other three columns are the classifications. So we see that obviously depressive disorders are one of the major reasons that people receive antidepressants. Pain, as you may or may not know, a lot of times people receive tricyclics. So 23% of the prescriptions had a history of anxiety and 35% had a history of pain. Again, this might be hard to see. I apologize. So this is a breakdown of the off-label use prescriptions that were broken down by prescribing department. The first one is internal medicine, and the number of off-label prescriptions was actually 27%. And then the next line, we have prominent diagnosis classes that appeared with these antidepressant prescription. We have hypertension, as you'd expect with internal med, pain, hyperlipidemia, anxiety, and diabetes. And then we listed a number of the diagnoses that were made and the drug classes that were prescribed using those. And as we can see, a lot of them are SSRIs, the most common ones. In that final list, we have the most common to the least common drug classes that are prescribed, and more often than not, SSRIs are prescribed the most. Pain medicine and management were 53% of the prescriptions were for off-label use for things like disc disorder, lumbar radiculopathy, low back pain, neck pain, neuropathic pain. And 97% of those prescriptions were for tricyclic antidepressants. And those are considered off-label. But the American College of Physicians just a few years ago recommended using tricyclics like nortriptyline and duloxetine to treat low back pain, but they're still considered off-label uses. So there's a little discrepancy between purely off-label and what evidence would suggest. So this is some results from our sensitivity analysis. We have the specialty in the first column, the prescription, some encounter diagnosis, the prescription diagnosis that was actually linked on the prescription, indication in clinical text, and then the excerpt from the clinical text. And we see for this prescription in internal med, the patient received paroxetine. The encounter diagnosis were hypertension and smoking, and the physician actually listed hypertension as the reason that they prescribed the diagnosis, which would not really make any sense. But when we dove into the notes, we found out the prescription was actually administered to treat depression. Another example from pain medicine and management, we see again lumbar radiculopathy. They received nortriptyline, disc disorder. The prescription diagnosis, the physician actually chose to skip that because you have the option of linking a diagnosis or just bypassing that altogether and issuing the prescription. And we see that the prescription was administered to treat neuropathic pain, and the patient was actually listed as being depressed 4 months prior to that. So we see 69% of the 270 randomly sampled off-label prescriptions did not have a structured diagnosis linked with the medication. These two categories here. Those would be oncology, prescribing citalopram, and the encounter diagnosis that was given to us was breast cancer. And then the other one would be gastroenterology and hepatology. Again, prescribed citalopram, and encounter diagnosis was insect bite and hepatitis C. However, 39% of the random sample of off-label prescriptions had included a physician-documented history of depression or cited depression as the indication. So we have here, in the case of breast cancer, the patient received antidepressant to treat depressed mood. And in the GI and hepatology, the patient received the antidepressant to treat depression and anxiety associated with PEG-Intron or for treatment of hep C. But you'd never know that if you're just looking at structured diagnosis. So how well did our methodology actually characterize the prescriptions? According to our sensitivity analysis, we accurately captured the physician-documented indication in 83% of the on-label prescriptions, and on average, the earliest diagnosis can be considered on-labels made 1.7 years prior to the prescription date. So in most cases, the 5-year look-back period wasn't needed, and as we can probably all agree, less than 2 years isn't that long to look back if we're talking about chronic conditions. So really, what does this all mean? You could probably guess the structured diagnosis entry is inadequate in EHR computerized provider order entry systems. Using a look-back window could help to fill in the blanks where diagnoses could be missing. Despite being off-label, though, there are a number of antidepressants that are widely used by clinicians to effectively treat pain, and that's the case with some other specialties as well. So if we go by purely off-label, the numbers reflected might not actually be true. Truly off-label uses of antidepressants might not be as high as previously estimated, as I just said. And analysis of structured data and NLP on unstructured clinical text can help to further validate findings. And that's it.
Great, so we have about 13 minutes left for questions. Set the clock for 13 minutes. And if folks can use the microphone, that would be terrific because we're being webcasted.
Hi, thank you. I have a question for the last presentation. I was a little confused looking at your consort diagram about when there were
that you weren't reaching a very diverse sample in terms of race and ethnicity. And I wonder, whether working with Mental Health America and who accesses their website and whether there are strategies to try and get the screening more broadly available.
Is this on? Yeah. I gotta go back and look at this for sure. As I said, it's just start really analysing this data. I'm not too sure how, in terms of the epidemiological data of the US population by race, it reflects that. It may accurately reflect the proportions. But in any of our work, I think it's always sort of recommended to really try to oversample in any of the ethnic minority groups to really ensure like true access to the information we're trying to provide and services. So I think it's a very valid point.
A question, or maybe it's a comment for Joseph. So it seems like the takeaway message, at least from the data that you were working with, is that we still have a long way to go before we can use medical record data to look at antidepressant use and off-label antidepressant use outside of specialty care. Is that a fair statement?
Yeah, yes and no. I mean, I think that it's getting better, but in terms of completely analyzing the data, then structured data is just not going to work to get a complete picture of it, because oftentimes, as we saw, that there's some other reason documented somewhere in the EHR. So we need to definitely work to structure the EHR better to glean information, but we also need informatics work on the back end to try and pull that out so that people can analyze it. And then in terms of psychiatric care, I believe that at least in our system, the prescriptions are now available on the back end. So if we were to conduct a new study now, there'd be infinitely more psychiatric prescriptions, and then we could analyze that as well.
But isn't there still the problem that there isn't a requirement for a diagnosis to be put in the record?
And that was a big hurdle. Is that we were kind of wondering like why you wouldn't need to link that? why you could just bypass it altogether. I wish I had an answer, but hopefully we can work with our ITS team to change that, because I feel like it's kind of a necessary step
Yeah.
without having to dive too deep into the EHR and do all these extra things.
Yeah, well, because the irony is, and folks who work with claims data know this, in the claims data, and not in the pharmacy claims data, but in an outpatient encounter or in an inpatient encounter or even in an ED record, you're always going to get a diagnosis. And typically, what we do if we want to understand psychotropic medication use on label or off label, even though we typically can't do it with a pharmacy record, we typically can look for outpatient, inpatient encounters. We can look at the days when those things happen, and we can sometimes make pretty good, educated guesses about whether the medication was on label or off label. So I say that all to say that I would hope that while Cornell and other providers who may have the same problem with their system, you've got to be providing the diagnosis data to get reimbursed. So the diagnosis data ought to be out there. And again, maybe like you say, this is an informatics problem more than anything else. Does that make sense?
Yeah, no, it definitely makes sense. And I can't speak to claims and reimbursement, so I don't know where they're finding it, but at least when we were given the data from ITS, we kind of had to dig and scrape for it. But it would be a lot easier if they were meant to, if they were required to link them specifically.
But included in the HR data would be the ADT, the billing data. So it might be that your organization wouldn't give that to you, but to your point, your hospital has to send out, your organization has to send out a claim with a diagnosis or they don't get reimbursed.
Right.
So that between the two, the clinical EHR and the admissions, discharge, transfer, the billing data, you would have that information, and perhaps combining them could help you to fill in where you don't actually have, Epic requires for a diagnosis, right? It's a volitional act to put a diagnosis, in there, but it's not a volitional act for, to get reimbursed for a claim.
Right. So I think you make a good point. I think that finding the data and where it is in the EHR, because it's got to be there at some point, right? So I think it might have to do with talking to the IT system about giving us the data and giving us the required data and looking in the right places.
To move away from EMR to suicide, Pei-Yin, I had a question for you that maybe I missed this in your presentation. You had a graph where you showed that the more community mental health centers you have, the higher the suicide risk. Yet if there's a delta down, there's also there's an increase in suicide risk. And I was trying to, maybe I missed, that seemed like contradictory, or maybe I missed something there.
So the between state association is actually the cross-sectional association. At that figure, we didn't look at within state changes, but when we look at the state changes, within the state changes, the slope actually was different.
Oh, I totally understood. I'm trying to get my head wrapped around, like, why would you have what's the underlying mechanism? That, yes, in cross-section, the more centers you have, the higher the suicide risk, but then if you take centers away, it also increases the suicide risk. Like, maybe you could tell us the story of how do you reconcile what, again, maybe contradictory.
Yeah, I don't have answer for that, but as far as I understand, there were huge variations in terms of state mental health funding and support in the community mental programs. Maybe Victoria can add. Yeah, all I know is after controlling for time, it varied. So just between state variations, that was not changing over time. We saw a split in terms of the beta. So that may result from the existing lack of mental health infrastructure or the lack of psychiatric or evidence-based practice in terms of mental health in the mental health settings. So, but I don't really have answers for that. I hope I can get more granular data to look at this kind of issues in more.
So one possibility could be urban.
Mike?
Oh, sorry. I just wanted to say say that one possibility could be urban versus rural. So for instance, like I noticed your headline up there was a few city clinics in Chicago closing down. But I know from experience that there were other mental health clinics that took over services for them. And typically people could probably travel relatively easy to get to them.
In
But if it's
urban.
a rural area, perhaps it's not so easy for you to go to another clinic. So that could possibly be
Yeah.
why there's not consistency and differences between states.
Yeah, I think that's a good point. Because rurality within a state did not change over time, so that could be captured in the time variant between state variations.
Yeah, and I think another important point is even in your data, you showed that a lot of people who commit suicide haven't received mental health services, right? So
That was that was from previous study conducted in 2017. They showed that 51% of those had serious thoughts. They did not really get formal treatment.
yeah, so that's a problem.
But they did, yeah.
Of course, but that's only then 51% of your population of people who commit suicide who might even be affected by the presence or not presence of clinics because they don't seek out treatment.
Yeah, it's possible, yeah. But in our data, we have to assume it's a random across states. So every state, yeah, can be this. Yep.
Oh, sorry. I actually don't have a follow-up on that one. If we can
Yeah.
move. Sorry. Hi. Sorry about that. I had a question for Paul about the mental health screening and a comment. So I've also been partnering with the National Eating Disorders Association to provide online screening for eating disorders. We're now screening over 200,000 folks a year, and the data are very similar to what you found. We found that of the people of eating disorders, only about 13 or 15% are currently in treatment. And then when we look at how many people click on some of these options that we present at the end of the screen, we get about 6 or 7% kind of uptake on any kind of clicks. And they aren't even as buried as it sounds like your decision tool may have been. They're rather prominent, although there's certainly kind of a lot on that final feedback page. But my question then for you is, you mentioned an online care delivery and working with MHA on that. And so I wondered, does part of that have something to do with how do you even kind of increase, you can present online treatment options if that's what you were getting at, but how do you also increase the number of people who are clicking on said options, and is that sort of part of the model that you're thinking about moving forward?
Yeah, no, thanks for the question. It's reassuring that I'm sorry you're having low uptake as well. If I get the answer, I'll let you know. I do a lot of tech development research as well, and part of most of the projects that I'm leading involves a lot of usability testing. And I'm not too sure how much is going on. I'm sure they've done quite a bit at MHA, but my hope would be that part of any sort of model would involve a lot of consumer involvement and usability design to ensure that folks are acutely aware that, when they get the PHQ-9 result, that this information is available here and it can be helpful. You should come and check this out and try to increase those numbers. So I think there's a lot that can be done on that end to understand what attracts folks to then look for further information. But it's still to be done.
Okay, thank you.
Great. Well, with 10 seconds left, thank you to the presenters, and thank you for sticking it out on day one. We'll see you tomorrow.
So I was thinking that, have you had any connection with the National Council on Behavioural Health?
No.
And they represent all the community mental health clinics, throughout I think they would be really interested to see your research, yeah.
Oh, yeah.
Because they can use it as an advocacy, like the importance of their work. And yes, thank you so much. Thanks for moderating.
Thank you so much. Yeah, that's a good idea. I actually compiling the exact address for every single community mental health centers as well as the outpatient mental health centers from the National Mental Health Survey.
Yes,
Yeah,
which I've
'cause-
used.